Good morning. Welcome. Hi, everybody. Thanks so much for joining us today. Welcome to our November 19th presentation. This is our second session. This morning we had an amazing session at 8:30 with Dr. Erin Knight. We have another amazing presentation. This is the RAAM Knowledge Exchange, and our topic for this session is opioid agonist therapy. And I am going to just give a quick shout out to the fact that it's Substance Use and Addiction Awareness Week this week, and that runs until November 22nd. There's lots of great opportunities out there for some webinars and some presentations and just some great information available. My name is Cheryl Giesbrecht. I work at Shared Health and Mental Health and Addictions. I'm your moderator this morning. And I just want to draw your attention before we get started to a question box. It should be in your upper right-hand corner of your screen. Our presenters have a PowerPoint presentation that they're going to share with us. After the presentation, we're going to open it up for questions. If you have any questions, please pop them in to that box as they come to mind so that we can pass them on to the presenters and ensure that they get answered. We're going to go straight to 10:30 this morning, and I'm just going to turn it over now to Daniel DeCombe. He is our host, and he's going to introduce our presenters and get our session started. So over to you, Daniel.
Thank you so much, Cheryl. Hi, everybody. My name is Daniel, and I'll be the host for this morning. That means that I'll be introducing our presenters and also letting them know when we're getting closer to the end of our session time. So I'm going to give a very brief introduction to everybody that you see in front of you, and we're very excited to have them all presenting with us today. Kirsty Mueller is an Anishinaabe nurse and the Addiction Services Program Manager for the Four Arrows Regional Health Authority. Arlene McLennan is the Director of Health Services, Adult Outpatient Services, and Mental Health and Addictions at Shared Health in Manitoba. Danielle Karanagudson is Health Services Manager for Mental Health and Addictions, supporting the ARC team and CRC and 2 Winnipeg RAAM clinics. And Chris Whaley is a registered nurse working at the RAAM Crisis Response Center Clinic, as well as Crisis Services in Winnipeg. Thank you all for being here with us this morning. I'm going to turn it over to our group who are going to be again presenting, and thank you so much for your time.
Just before we start, I'd just like to do a little update. I've actually changed positions since my bio went in, and I now have gone back to the manager of health services for Cody, Epis, and Most. Some of the work that I did during this time period was as the director, but there's certainly some crossover there.
Okay, we're going to get going. Chris, I think you start with the slides.
I need you to flip it.
Yeah, it's flipped.
Okay, I'll do the acknowledgement of the Indigenous, ancestral, and territorial lands. So health services across Manitoba are provided in facilities located on the original lands of First Nations, Inuit, and on the national homeland of the Red River Métis Nation. Manitoba's health authorities respect that First Nation treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis people in the spirit of reconciliation. Health services across Manitoba are provided. Oh,
that's a repeat.
That's a repeat. Sorry about that.
I said it twice.
So before we get into the nitty-gritty of our presentation, I'm just going to give a little spiel about the RAAM clinic. RAAM stands for Rapid Access to Addictions Medicine. Typically, an individual can present to their family physician or maybe a walk-in clinic regarding their challenges with substance use. The benefit of attending the RAAM clinic is that we're all specialized and educated in addictions medicine. So we're low barrier, easy access to wraparound addiction care for any substances, including alcohol, opiates, and stimulants. So whether that's fentanyl, Percocets, cocaine, meth, or beer challenges, we kind of deal with it all. We provide options for walk-in, virtual care, and once you have been assessed at our clinic, every appointment going forward is going to be booked. We do provide follow-up care to 18-plus-year-old individuals, as well as provide care to youth that are under the age of 18. Our clinic is staffed by an addiction physician, a physician assistant, nurses, a rehabilitation counselor. So that's the person who would connect an individual with detox treatment, outpatient treatment options. We have a brief treatment counselor who will provide 6 to 8 sessions with an individual on whatever challenge they're facing, whether they want to develop new coping strategies, whether they want to deal with grief, whether they want to do some goal setting. We have a crisis worker who's the friendly face you meet at the front desk, and a peer support worker, a gal who comes with lived experience, who's really providing hope for people who are presenting to our clinic. As I mentioned, all services are walk up or / walk in initially, but every appointment going forward is going to be booked. So our topic is going to talk about how RAAM became connected with the community of Garden Hill. So Garden Hill requests support for substance use. How this all kind of started was mapping data identified the area of Island Lakes as an area of high need. So Island Lakes consists of the communities of Wasagamak, St. Teresa's Point, Garden Hill, and Red Sucker Lake. The community of Garden Hill and its nursing station recognized that its members were struggling with substance uses, so they were requesting addictions treatment. At the time, there was a pilot OAT program in Red Sucker Lake, which started to provide addictions treatment for members of that community specifically. This increased community access to addictions medicine in these remote communities. So just a little map of where we're talking about it. This is the province of Manitoba. And if you just see kind of up at the top of Winnipeg, that whole area that's circled is considered Island Lakes, and Garden Hill's right there in the middle. Some pictures of our Garden Hill nursing station. That's the community and the central point where we had a lot of our collaboration. RAAM connects with the community of Garden Hill. So another way this all kind of started was individuals from Garden Hill were being medevaced or sent to Winnipeg for medical reasons, and then they were being started on opiate replacement treatment therapy while they were in the hospital and then referred to the RAAM clinic. We also had individuals from Garden Hill who were already in Winnipeg for whatever reason, whether it was a medical reason or visiting family, and they were presenting to our clinic on a walk-in basis. And then Garden Hill Nursing Station also started to send referrals to RAAM for people in their community that were needing substance use treatment. With every positive, there's always a little bit of challenges. So some of the challenges we noticed were people were coming to our clinic without prior personal contact with RAAM staff or an explanation of services. So for example, people were presenting to the clinic and were like, I'm here for treatment, but they weren't sure what the options were, how it worked. They didn't know us, we didn't know them. So there was perhaps a little bit of anxiety and stress. Individuals weren't aware of the expectations and the commitment for starting for opiate replacement therapy. So for example, if you go to the doctor for a sore throat, they can prescribe an antibiotic. You come in, you get your prescription, you leave. With opiate replacement therapy, it's a bit of a process. We have to dose you, we have to reassess you, how are you feeling? And then we'll continue to tweak that dose until you're feeling really good. It's a bit of a process. So a lot of people weren't aware of what that meant, you know, going to the pharmacy every day, having to have blood work done, all those sorts of things. There was also minimal consideration for the individuals arriving with their children. So if an individual is coming here to start on opiate replacement therapy, they would be here for a few hours, but they would have no childcare for their children. So we'd have little kids here, and we were really creative and up to the challenge. But it's not like the best situation for parents to have their kids for 3 to 4 hours in an addictions clinic, right? Sublocade. So once we have an individual started on Suboxone, which is the oral opiate replacement therapy, there's the option to provide them with this injection. So Sublocade is a buprenorphine extended release, long-acting injectable medication for the treatment of moderate to severe opioid use. So once we have an individual stable on the medication Suboxone, we then have the option to give them this injection. And the caveat would be that they would have to have blood work done and then come into the Winnipeg every month to receive this injection. But it provides a little bit more flexibility in that you wouldn't have to go to the pharmacy every day to receive your medication. You can travel, and in cases where individuals are living in northern communities where they're not able to go to the pharmacy all day, this medication would provide that sustained release of the medication over the course of the month to help with their cravings and withdrawal symptoms. We started to notice the referrals to RAAM began to really increase, especially from the community of Garden Hill. So a First Nations RAAM working group established through the RAAM Hub created a referral form for northern communities. RAAM clinics in Winnipeg began to receive a large number of referrals from Garden Hill requesting RAAM services. Word of mouth from RAAM clients advised that community members were talking about RAAM services in Sublocade. So we were doing all these Sublocades on individuals from Garden Hill, and you really develop a rapport with these people and get to know them, their families, and what's going on in their lives. And they would openly tell us, I'm telling all my family and friends about this. This is great. Melanie was a public health nurse that works out of the Garden Hill nursing station, really took spreading the word of RAAM and opiate replacement therapy under her wing, and really started to promote OAT in her community, which thus increased the referrals to the RAAM clinics in Winnipeg. Digital Front Door connects with Garden Hill. So Digital Front Door is a virtual platform that RAAM utilizes to connect with individuals virtually. So instead of presenting to our clinic on a walk-in basis, we're able to assess and meet individuals and develop a plan of care with them virtually, and then book them an in-person appointment. Well, this really worked in a lot of ways with our northern relatives. It enabled us to connect with them virtually prior to them coming in. It enabled us to develop a rapport. We were able to do this in-depth assessment prior to them coming in, really getting to know them, finding out what their challenges were, explaining the services, explaining the expectations, which allowed them to perhaps decrease their stress levels when they came in. They already knew what to expect. They have seen me virtually on the computer. They knew the expectation was they were going to be here for a week or two. They knew what the plan was. It also allowed us to provide medication teaching, harm reduction teaching, inquire if they have a Narcan at home, and we could direct them to attend the nursing station if they didn't have it. It also allowed us to provide the suicide risk assessments for the individuals virtually and develop a safe plan as needed. There were limitations with Digital Front Door. Many individuals did not have access to the internet or phone. One of the ways we went around that was we connected with the nursing station, who would then set up the Digital Front Door platform for individuals to then attend the nursing session and then meet with me virtually. The challenge was that the nursing station had limited capacity and ability to provide the support for everybody that needed it. And there was also that privacy aspect. It kind of left out that anonymity portion of it, because a person would still have to go to the nursing station and divulge, hey, I'm struggling with this. Can I use your computer to do this assessment? The individuals who did choose to be assessed at home had limited experience using the virtual platform. As things progressed, a First Nations RAAM pathway was developed. DFD provided the linkage between FNIB nursing stations and RAAM clinics. This increased and improved access to OAT in First Nation communities. Aboriginal Health and Wellness RAAM clinics, they were the centralized intake for all northern referrals. So nursing stations in these northern communities would do a brief assessment on the individuals from their communities. They would send that referral form to AB Health, who would then allocate the referrals to the different RAAM clinics in Winnipeg, depending on appointment availability and individual preference. And they noticed there was a high amount of referrals coming in from the community. This past summer, there was the Manitoba wildfires. So we noticed that individuals who were scheduled for Sublocade injections in Winnipeg, RAAM clinics, were often missing their appointments because they weren't prioritized to fly out of the community due to decreased hotel capacity. The majority of referrals from RAAM Garden Hill nursing station stopped because the majority of the community was evacuated. We tried to get around this a little bit and kind of had a DFD walk-in clinic, which meant that the nursing station just kept their DFD platform open and people could just randomly present, and they would call me to give me a heads up that someone was here to be assessed via DFD, and then I would just assess them and book them an appointment in. But as time went on, more and more people had to leave the community because of the wildfires.
Yeah, so during the wildfires, there was a number of congregate sites that were set up throughout the city. And when individuals or relatives were evacuated from their community, they would be assigned to these particular sites. There was Billy Mozianko initially was used as a reception site, but after a while, the reception site moved to Lila, and there was also the identification that there was individuals who were coming from various communities who needed more support. So Billy Mozianko was set up as a smaller congregate site, and it really focused on person-centered harm reduction approach, and it was to support those evacuees who were having difficulties or in the other sites related to substance use, mental health distress, or trauma-related behaviors. And the goal of Billy Mozianko was to have a low barrier, culturally safe environment where individuals could stabilize, connect to supports, and be treated with compassion. It was led by the Department of Housing, Addiction, and Homelessness and operated with a community support model. One of the great things I think about this was the amount of collaboration and partnerships that was developed during this time. There was a variety of service providers and a strong cultural support focus. Again, we're ensuring that relatives receive culturally safe, trauma-informed support and harm reduction services. So if a relative was at one of the other congregate sites and there was identification by staff or other individuals, then that person would be referred to Billy Mozianko, and arrangements would be made for them to come over to Billy Mozianko. And when the individuals came to Billy Mozianko, there was a lot of community agency support. Shared Health had nurses and mental health support. Public health was also involved. Nadinoe Mac provided a lot of support and services. So it was a real collaboration with everybody. And what we wanted for individuals that went to Billy Mozianko was that they felt welcomed, they felt respected, they felt that this was going to be a safe place for them, They were greeted by peers and individuals from their communities. We tried to make it culturally safe. Outside, and it's unfortunate we don't have a picture, but outside, one of the agencies had brought in the fire keepers, and there was a sacred fire that was going. They had elders there to meet and support and speak with people. There was ceremonies. We made sure that nutrition was important, shelter, rest, hygiene. There was harm reduction supplies that were available to individuals. All the staff were trained in that regards. We would link people with medical support services if they did need referrals to RAAM, or how to connect with RAAM, how to connect with detox, and for treatment beds, that was also arranged for them. And it was really about meeting people where they were at.
So I'm going to hop in here and just talk a little bit about the detox bed pathway. So there was a need for a pathway to detox beds for folks identified in community who were seeking that next step for themselves. So Main Street Project provided priority access for Northern relatives, which meant that we had set aside one female and female identifying and one male and male identifying bed for Northern relatives to access if they decided that that was what they were wanting to do. So the RAAM manager, that's me, became the point person for those beds. So the frontline staff working with individuals at Billy Mosienko and throughout the city, like at the hotels and other reception sites, would identify individuals who might be wanting detox. In particular, we had really strong partnerships and relationships with Kim, Nadinaway Mac, and the WRHA and Shared Health staff. So individuals who were identified would be supported in coming to the RAAM clinic and be assessed and referred from there to the bed. The assessment process is fairly quick. I mean, it can be done within an hour. There's a form to fill out, and then the individual would go straight to Main Street Project Detox. So out of this, we saw many successes. There was a lot of consultation and collaborative care planning that came from this, a lot of relationship building between sites, and opportunities for people to attend detox that hadn't existed prior to that. And then the challenges that came from that a little bit was one person being on call for the pathway. Often there were people who were referred to RAAM for the assessment and were identified as being too high acuity for Main Street Project detox beds. And we, at that point, needed to determine other pathways, but we had no priority beds. So an individual might need RR2 at HSE, the addictions unit at the hospital, but we didn't have priority beds. So we had to do some planning and strategizing around how to navigate that. It's also creating this pathway also ultimately resulted in fewer Main Street Project detox beds being available for the RAAM clinics that referred to those beds. So that's all the RAAM clinics in the province referred to these beds, and we were holding back a bed at each facility for this pathway.
So the other pathway that we needed to explore was for treatment beds, so that we felt that there would be some people who during the evacuation and were in Winnipeg may want to go into treatment. So we did have discussions with Winnipeg Regional Health Authority, Tamarack, Bruce Oak Recovery Center, and the Behavioral Health Foundation. So with Tamarack, they were able to provide us with information in regards to how someone could connect with their services and use their navigation support and that information. So we were able to provide that information to individuals who were at any of the congregate sites or the hotels. In regards to Bruce Oak and the Behavioral Health Foundation, so we met with both of those agencies, and what we did was kind of looked at a way that we could prioritize evacuees who identified that they wanted to go into treatment. And then we came up with ways to make the referral process as simple as possible. So, you know, we had some meetings with the leadership at Bruce Oak and Behavioral Health Foundation. with Bruce Oak Recovery Center. I'm kind of summarizing the slides, so that's why Danielle's looking at me. What we did in regards to the referrals was that with Bruce Oak, we did condensed to a one-page referral. And then if anybody could contact the manager director for most was the contact person for the treatment bed referrals. And it could be our staff, it could be somebody from the community agencies, it could be somebody from Kirsty's group. Anybody could reach out to us and say, listen, we have this person who's here and they would like to go into treatment. So then what would happen is that they would contact, again, the manager or director. They would provide the information about that individual, and that would start the referral process. An email would be sent to Bruce Oak or behavioral health, letting them know that, hey, there's a possibility that this person might come. I think the connection with the detox beds was that certainly some people went into detox before going into treatment. So there was that kind of linkage back and forth between Danielle and myself in regards to those referrals. And then what would happen would be once I had the information from the person who was wanting treatment, then I would call them and just confirm that yes, they wanted to go for treatment, and then we would complete the referral. And then for Bruce Oak, we would send it to their intake person. And then if the individual was in detox, Bruce Oak had that established relationship, and they would make the connection. And wherever the individual was, they would make the connection, and then they would arrange for the person to be admitted. And the person could was eligible for both they could be part of the in-house treatment or their day program. So that was two of the options. And then with behavioral health, we would complete the referral, and then we would fax it to our contact there, and they would prioritize the individuals for the admission to their program. So I was really trying to streamline it as much as possible and make it as simple as possible for the folks who were wanting referrals. And so that would be how people would get into treatment. Just during the wildfires, there was many different partners that were involved. As I was saying, there was the treatment centers, emergency social services, 4 Arrows, and this is where I think with Kirsty and her group, there was a lot of partnership. A lot of the other community agencies, Main Street Project, Manitoba Harm Reduction, Dinamak, the Turtle Team. So lots of partnerships. We met every day at the height of the wildfires to kind of update and keep each other in the loop about what was happening, where the stress points were. And I think there was a lot of pivoting that happened during that time. Mm-hmm. So I'm just going to talk a little bit about one of the things that also evolved during this time was with some of the Garden Hill relatives. So as Chris had said, that there was identification from Garden Hill that there was a number of individuals that were requiring support for OAT. And initially, Chris explained her process, and then a lot of individuals who needed that longer term kind of follow-up would be referred to the MOST program. And so the MOST program prior to the wildfires had between 70 and 100 individuals on the caseload that were being flown into Winnipeg, and they would receive their sublocade or meet with their provider, meet with the case manager, and they would receive their injections. So that was working, and then the wildfires started, and there was no hotels. It was really difficult to get people into Winnipeg to receive the sublocade. So there was a discussion in regards to, like, how do we make sure that our relatives still are getting to receive this type of support? So we talked about the possibility of the nurses going into the community, going up to Garden Hill, and being in the community to provide the injections. And so that was done through the MOST program. And actually in the presentation here, 3 of the nurses that are involved in providing the services in the community are actually here. So Roxanne, Susan, and Michelle. are the nurses that go to Garden Hill on a regular basis. They were, pivotal in the work that was done, with Christy and her team in regards to when folks were evacuated to Winnipeg and making sure that individuals were able to access the OAT treatment. So we're really glad that they're able to join us today. We're with the MOST program, which is the Manitoba Opioid Support and Treatment Program. We're a team of providers. There's physicians, nurse practitioner, clinical case managers that work out of that office at RPC on Magnus. So that's where we're located. The services that we provide is the counseling and support, health education and guidance, prescription of the OAT medications, disease prevention education, linkage to community supports, regular contact with our staff, and then harm reduction and education. So certainly during the wildfires, we were like, okay, we need to do something different. So shared health, mental health and addictions staff met with shared health leadership to talk about some of the concerns. Then we met with the director from FNIB and discussed the possibility of sending the 2 nurses to the community. Initially, it was 2 nurses going to the community twice a week, and to send the nurses there. So that was agreed to. So then we were able to send the nurses into the community. And we work closely with the nurse manager for Garden Hill. The public health nurse, Mel, that Chris was talking to, has been a real big support. And we also worked with the charge nurse at the nursing station, and again, our friend Kirsty. So in regards to how we would communicate, we did let the relatives know that we would be able to provide the service to them in the community during this time. The nurses would get flown in for 2 days. Now we go for 3 days. We've kind of extended the length of time that we're in the community, and we've extended the hours that we provide the injections just to kind of meet the needs of the relatives. And the individuals would be notified by most staff that the nurses would be in the community. And then they also have a community Facebook page, and they also have radio and television where the announcements would be made. And then over those 2 days, the nurses would provide the Sublocade to the relatives. During the wildfires, so we went and we did the initial trip up. And then shortly after that, the folks from Garden Hill were evacuated into Winnipeg. So at that point, we kind of had to quickly come up with, now what do we do? How do we make sure when folks are in Winnipeg that they're getting their injections? So the nurses that were involved in this project, we knew who the individuals were that required the Sublocade. We tried to connect with the congregate sites where they were located to make sure that we could let them know that they could still reach out to us, they could still get their injections. We also reached out to Kirsty because she also knew where some of the relatives from the community were evacuated to. And people, initially the majority of folks came to Winnipeg, but then after a while there was some movement to different parts of the province. So there was some coordination with Brandon and Portage to make sure that individuals who ended up there also were able to get their Sublocade. And the most nurses and Christy and her team worked together to set up clinics out of the Four Arrows office to make sure that people were getting their Sublocade. So we did some at MOST, we did some at the Four Rivers Clinic, and once things settled down with the wildfires and people were returning home, then we had to pivot again in regards to providing services back in the community and reconnecting people and making sure that they knew that they would still be able to get their Sublocade. And during the time that folks were in Winnipeg, there was also additional referrals that were made for relatives wanting Sublocade and OAT treatment. So those numbers were also increasing during that time. So fortunately, people were able to return home, and we were able to come up with a plan with the nursing station and with 4 Arrows and most in regards to how we would provide Sublocade in the community. The most nurses would go up every 2 weeks, and we extended it to 3 days that we'd be in community providing the Sublocade. And then the week that we weren't there, Kirsty's team would be going up and providing Sublocade. So we go up right now. We do have 3 nurses that are involved with the Garden Hill relatives in that team. So we have a kind of a mini team that works together, because there's a lot of prep work that the nurses have to do in advance of going to the community, making sure that everybody's injections are available, contacting the individuals, making travel arrangements, to ensure that that all happens. So there's a lot of planning that also goes into this. So they'll go up for Wednesday. They fly up on the Wednesday morning. They'll arrive in the community. They'll have the clinic usually starting around 11 or 12 and go till 8 in the evening. And Thursday, same thing. Friday, they usually leave the community around 1:30 and come back to Winnipeg. And they fly out from Perimeter Aviation. So there's right now we have about 100 individuals that are relatives from Garden Hill that are getting the Sublocade. Some people still do come to Winnipeg, so what we're planning on doing is that 3rd nurse, it will kind of, when people are in Winnipeg coming for the injection, that they will be kind of coordinating with that individual to get their Sublocade. Chris kind of alluded to this, but some of the reasons that people do come to Winnipeg is that they might have other medical appointments here. So they're seeing somebody else, so they come and see us. They might be in Winnipeg for other reasons. And some people, the privacy issue is a, in a smaller community sort of thing, that anonymity, is a little bit more challenging sort of thing. So that's something that we're also looking at. I think some of the feedback that we've gotten has been very positive, that a lot of the relatives really prefer having the Sublocade and the OAT support provided in the community versus coming to Winnipeg. I know there were some individuals who just never came to Winnipeg prior to this. So the fact that they could receive the Sublocade in their community has been very positive for them. The Grand Chief and Council for Garden Hill were also supportive of this process, and we're happy that we were able to provide the support. And again, just that privacy issue. So we have been going up to Garden Hill since July, and during that time, we've certainly seen an increase in the number of individuals that are coming to the clinic. Folks are now more aware of when we're going to be there because we have that routine. Initially, we weren't sure how long that we were going to be in the community, but now we know that we can continue to provide this service till the end of March. So that's kind of making things easier to plan for the folks. And I'm going to hand it over to Kirsty.
Arlene. Yeah, so I'm going to take over and introduce 4 Arrows Regional Health Authority. So we are a very small but kind of mighty team. So it's myself, Joshua Munoz, who's our registered nurse that came on, and Sheena Wood, who's our medical office administrator that joined us July of this year. We do have a clinic right across from Perimeter Airlines. Both of Sheena and Josh did grow up in our Island Lake communities and speak our language, which is extremely important to 4 Arrows, to have people that can meet people where they're at, speak their language, make people feel more comfortable. Next slide. So 4 Arrows Regional Health Authority, like we kind of said, this is a regional health authority for our Island Lake members. As we kind of already stated, the Island Lake consists of our Garden Hill Anishinaabe Nation, St. Teresa Point Anishinaabe Nation, Red Sucker Lake Anishinaabe Nation, Wasagamak Anishinaabe Nation. We do have an office in the city here in Winnipeg, and we have a variety of health services for our Island Lake members. We're governed by a Grand Chief, and then each community has Chief and Council. We work collaboratively with our community health services and partners, including Shared Health, Indigenous Services Canada, our nursing stations, provincial supports in order to access or increase healthcare access in our Island Lake region. for both provincial and federal stations. This is a picture I actually took after the wildfire when I was taking a helicopter trip from Garden Hill to Red Sucker Lake. So it was quite a sight to see from the air. So this was part, you can see part of our land that was unfortunately taken during the wildfires this season. So just a little bit of background about Four Arrows. So in 2018, our Island Lake community members walked to Ottawa to raise awareness for our addiction crisis and our overdose crisis in our Island Lake communities. Following this, Indigenous Services Canada funded a feasibility study for a FARHA addiction treatment program. And then the pandemic kind of hit, and during COVID-19, a full-time OAT program was established in Red Sucker Lake and Nishnoo Nation to meet our urgent needs. Dr. Erin Knight was our medical director, and Dr. Joanna Lynch was our prescriber and our doctor, who actually went into community and recognized the huge need of people that were using opiates and were now going into withdrawal because they were, due to the pandemic, stuck in their community. There was no supply coming in and they were unable to leave. And we had a lot of sick people, and the nursing station was not able to accommodate or treat patients like this. So building on these efforts, the Manitoba mobile team to increase community capacity and access, the Medica program, was also launched, was a pilot project for 1 year. But the RSL OAT program was a full-time program with 2 nurses, including myself and another nurse, Heather, who basically went 2 weeks in and 2 weeks out. So there was a nurse full-time in Red Sucker Lake to be able to do starts for OAT or ORT in the community of Red Sucker Lake and Nishnoo Nation, which made a huge difference. That community has just for reference, that community has an in-community population of just over 900 to 1,000 people that live there. And throughout it's 4 years now that we've been in Red Sucker, we've had about 180, just over 180 people that came through our program. So that total is a large number. The Medica team, or the mobile team, also went into St. Teresa Point and Wasagamak, so 2 of other Island Lake members, and then another northern community as well. And we're able to do successful OAT starts. That program, like I said, was a pilot project and funded for 1 year, so it's no longer working. Or it was for 18 months. It did expand addiction treatment accesses in our remote Indigenous communities for our relatives. It focused on mobile addiction services, local capacity building, and harm reduction and education. So we were actually bringing services to the communities for the first time, instead of them having to travel out to Winnipeg, Brandon, or Thompson for other services. So the Manitoba Nishnoo Mobile Addictions Network, or MAMAN as we call ourselves, came through out of the RSL OAT program. So we, once we were established in Red Sucker Lake, and we learned a lot out of that program, and we love being there, embedded in the community, for myself for 3 years and Heather for 4 years. We provide harm reduction services. We supported a lot of pregnant individuals throughout their pregnancy on OAT. I think we say that we're aunties to about 15 babies in Red Sucker Lake now, that we help support the moms through their pregnancy and the families through their pregnancy for people that were using substances. But after that, when our numbers kind of slowed down, we had people graduate and come off the program, we realized that there was a need in our other Island Lake communities, and our Grand Chief, our medical director, myself came up with the Manitoba Nishnoo Mobile Addictions Network. So we have a hub clinic in the city here, which is perfectly right across the street from Perimeter Airlines, so easily accessible for our relatives that come down or are traveling back up north. We also have a pharmacy that is right there. So we decided to open our hub clinic and provide support. So we do OAT. We consider ourselves like a mini little RAAM clinic, without having all of the bells and whistles that RAAM necessarily has. Like I said, it is a small team just with the 3 of us for now, but maybe we will be hopefully expanding. And we do withdrawal support, assessment, medication follow-up, harm reduction services, supplies, education. We're a pathway to STBBI care and testing. We are lucky that in some of our communities, our relatives already have great relationships with our public health nurses, and have had their testing done already by the time that they see us. And we're able to kind of follow through and provide any services for that. We are able to also do referrals to detox, residential treatment services, housing or medical supports, and other social services. However, it is just a small team, and right now we're really focused on OAT and ORT because that's what the community of Garden Hill has been seeing that we need. So like I said, where we provide services right across from Perimeter Airlines, people are able to get off the plane and either come and see us for some harm reduction supplies if they need when they're coming to the city. Our nurses also travel to community to provide OAT. So like I said, with the Red Sucker Lake, we were in community almost 100% of the time, and they definitely benefited from having addiction services in their community. We can also see people in the city and bring people down and see people at our urban clinic as well if they need. Who we're working with, we partner with a lot of people, shared health, addictions physicians, and like I said, we do have a pharmacy right in our clinic. So when people are needing to start OAT, we have a pharmacy right there that they can dose or receive additional prescriptions that they need. Currently, we are in Red Sucker Lake, Garden Hill and Nishnaway Nation, and we have a planned expansion to St. Teresa Point and Wasagamacc and Nishnaway Nations as well. So there's always barriers and limitations, like everyone else kind of said. So there's always communication challenges, including language. So it was very important to us that we hire staff that are very familiar and speak the language. That's a priority for Four Arrows Regional Health Authority, is to have people that can converse, and it makes people feel comfortable. Our relatives that are from communities to have a nurse or be greeted by someone that can speak their language is very important. There's a lot of stigma from community and healthcare providers. Privacy concerns has already been mentioned. Our communities are very small, so accessing service at the nursing station can be a barrier when your auntie works the front desk and you don't want them to know why you're coming there. Travel difficulties, as mentioned, all our communities are fly-in only. They do have a winter road that will be coming later this fall. It's open for a small term. It's 15 hours to drive. Flights are very expensive, so high cost and limited availability during flights. Flights are canceled all the time and late all the time. And then lack of a local pharmacy, like that was already mentioned. There is no pharmacies in any of these communities, so people aren't able to go and do daily dosing. There's delays in accessing OAT withdrawal medications and STBBI treatments, and that's for a variety of reasons. Our nursing stations, as every place, there's a nursing shortage. And then, a nurse is not a nurse is not a nurse. So if nurses and physicians in these communities don't have addiction training, or they're not comfortable administering Suboxone or methadone, there's no methadone in communities, but that's certainly a barrier for people to being able to access treatment. And then also we knew that the need would be very high, that once we opened the door for being able to provide services, we needed to be able to follow up and continue to provide services for people. We didn't want to start something that we weren't able to follow through with and have people start services and then no follow-up. The reliance on nursing stations or shipments, they are overwhelmed in nursing stations as it is. So adding to their barrier, we didn't feel that we could do that in talking with the various nursing stations. There is limited harm reduction supports or supplies, I want to say, in communities as well. And that could be, there could be barriers from the community itself. There could be barriers and stigma, maybe at the nursing station, and not having access to 24-hour harm reduction services. And then also the privacy, again, is a big issue. Inconsistent access to safer use and safer sex supplies, lack of overdose prevention services, high cost of substances in the city or in the community. So you know, if you talk to your clients or your patients and you find out what substances cost in the city, if they're paying, $10 for a dilly in Winnipeg, they're paying $40 for a dilly in Garden Hill. So the cost is much, much higher for that, for alcohol, for food, for everything in the north. Price inflation increases risk of harmful patterns of use. So people may not be able to use for a number of days due to either access to services or the cost of it. And then their tolerance goes down. And then when they are able to use, it puts them at a higher risk, creates additional safety concerns and vulnerability for this vulnerable population. So our evacuation response. So during the fires, a lot of this was kind of already talked about. We did collaborate, Four Arrows did collaborate with Shared Health. We did a lot of tracking of location of individuals. We were able to go to command centers and see the lists of people where people were at. So we were able to try to find people who are currently on OAT and get them their services. We offered an urban clinic to the most team, so they came and hosted a clinic there, again, right across from Perimeter, close to a lot of the hotels where people were staying. So it was easily accessible for people. We did a lot of community outreach. So we were visiting the congregate sites and settings. We provided nasal naloxone and harm reduction services and supplies to people, and then also the Turtle team and other community organizations that were providing services to our relatives. We offered support of our Billy Mosey ankle. We would go visiting there and connecting with our community members and seeing whatever kind of support it was that they needed. Clinical support, we did provide emergency OAT inductions to community members at our urban clinic. If they were an Island Lake member and they needed, and they weren't going through RAAM, they could come and see us, and we had a prescriber, and myself or Joshua were doing starts with them at our clinic. And leadership and coordination, so consulting with other organizations. So we would do a lot of partnerships with our Shared Health provincial, federal programs, and our nursing stations, community health. There's a lot of behind the scenes community health work that goes on in communities that people may not be aware of. We have NADAP workers, community health workers, band constables that all live and work in these communities, and they are a great service to our communities. They want to serve their people in communities, and so we're a great partnership with them. And future planning. So I'm just going to talk about the future, and then the future for the MAMAN program. So like I said, we are currently in Garden Hill, and we continue to service our Red Sucker Lake and Nishnoo Nation patients as well. We do have plans to move into St. Teresa Point and Wasagamec as well. I will say, since we have started going into community, when people return from the fire, we are also going in, myself and Joshua, every second week. So right now, between the most nurses and MAMAN, there are addiction nurses in the community of Garden Hill every week, which is amazing. So they're able to provide Sublocade injections to people that are already on OAT. Joshua and I can also do starts for people that have not initiated OAT previously. We're able to actually start people in the community. So since the beginning of September, we have started 40 brand new patients, or probably over 40 brand new patients now on OAT, and transition them to Sublocade. If you listen to Dr. Knight's presentation prior to this, she talked about the macro dosing off-label. We are doing some dosing in the communities and getting people rapidly onto Sublocade, which allows us, if they're meet criteria and they're medically stable, we have a provider and doctor in the community where we're doing that. So we've seen over 40 people. We know that the need is high. We have 60 people or plus now on our wait list that want to start in community. And I will just say, kind of as a last minute thing, we were able to access a lot of this vulnerable population that were not able to leave the city. So we're able to start a lot of mums that for childcare reasons cannot come to Winnipeg and do a 7 to 10 day start in our RAAM clinics, but are able to come to the nursing station and see us. So we've met a lot of patients who would not have been able to access this service previously. So we look forward to moving forward, and thank you very much.
Wow, so thank you so much, all of you. That was an incredible amount of information, and so clearly and concisely presented. I want to let everybody know that the information and the slides are included in the materials attached as a PDF to this meeting, so people who are in attendance can download if they want to read any of the information that was provided. We have a few minutes left, so I'm going to go to the questions now, if that's all right with everybody. There are 2 questions that have come in so far, but we still probably have time for a couple more if people add them. The first question is, and this came in actually at about 9:56, so it's probably, I think, directed towards Arlene and Danielle. How do you decide on one bed, and who could access detox? So I'll turn it over to you.
Yeah, that's a great question. So one bed was where we started as at the beginning and determined over the course of the summer during the wildfires that was meeting the need. We had the opportunity to re-examine that if needed. We could talk to MSP and sort that. We found that was the right number of beds, and it was really first come. Like people were identified, they would come in and we would get them into a bed. And fortunately, we didn't run into any flow issues around that. We didn't have 2 or 3 people lined up for the same bed. Had we encountered that, I think we would have pivoted and come up with a new strategy around that as well.
Mm-hmm.
And the same thing for the treatment beds. We kind of, we just selected what we thought would be adequate, and then there was always that ability to have a discussion. And I think one of the things that, you know, I noted was that during the time like July and August, when, you know, there was a lot of evacuation, people going back and forth, a lot more of the referrals started to come towards the mid-August, beginning of September, when things had started to settle down a bit, sort of thing. So again, there was that ability to speak with our partners if we needed more support.
Mm-hmm. Thank you. Another question that came in about 10 minutes ago. It says, does MAMN support youth as well, or only for adults?
Good. That's a really good question. It would depend on the age. In the Red Sucker Lake program, we did have people that were accessed our program. I think our youngest was 16 and 17, and that was with discussion with our medical director and our physician that was prescribing. There wasn't a lot. That might have been 1, maybe 2. We would probably defer if we got a referral in Garden Hill through the CRC and youth pathway for that one. Yeah.
Thank you, Kirsty. I don't see any other questions coming in at the moment. We can give it another few seconds if there are any. We do have some saying thank you for the presentation, others saying great job. For those who are in attendance, as a reminder, the materials are available for download, a PDF of the slide deck that can be downloaded and printed out if you need. Yeah, just more thanks coming in and applause, reactions, and so on from people who have been here. So I think we're at 10:30, so we'll wrap it up. Thank you to all of our presenters for again doing such a great job and educating us about the things that you've been working on. And we so appreciate your time during these knowledge exchange days. Thank you everybody for coming and for your questions and for your attention. We appreciate you, and we look forward to seeing you at the next session. Thanks everyone.